Thanks, Susan. And welcome, everyone. Thanks for joining this afternoon. Today we have Deborah Assayag, who's a colleague in the respiratory division at the MUHC. So I'm super excited to hear this talk. She has in addition to her clinical training in internal medicine and RESP, which was done at McGill, she was at UCSF to do some additional research and clinical training. She got a master's degree in biostats and epi, and now is also leading the interstitial lung disease clinic. So rich data to work with and a major health problem. So I'll turn it over to Deborah to tell us what she's up to.
Super. Thank you so much, Ben. That was such a kind introduction. Way to set the bar high. So I'm going to be talking about a few of the projects that I've been working on over the past couple of years and stuff that's work in progress and work that's going to be coming soon. I did present a little bit of this work at last week's Department of Medicine Research Symposium. So I do apologize for those people who saw me, although then it was only 10 minutes. So I will expand a bit on what I talked about last week, but I do apologize if there's a little bit of a repetition for you. So I like to think of my work as trying to improve the care of patients with interstitial lung diseases. And these lungs are lungs of a patient of mine who died of pulmonary fibrosis. These are very abnormal looking lungs, very fibrotic, very end stage. And so everything that I do, I think about my patients, and my patients with this disease really drive me. I do want to start with disclosures and conflict of interest. So I participated in advisory board committees for Roche and for Boehringer Ingelheim over the past 3 years. I also received grant money from Boehringer Ingelheim, grants that were paid to the RI-MUHC for my research. And I have participated in clinical trials of medications for idiopathic pulmonary fibrosis in the past few years. So the objectives of today's talk, I want to show how I'm using collaborations, both local, national, and international, to work on improving care for patients with interstitial lung diseases. And I'm going to show you how I do this with sort of two themes of my research program. The first theme being understanding the mechanism and pathobiology of ILD related to autoimmune diseases. And the second sort of theme is going to be to look at gender and racial-based inequities in access to clinical care for patients with interstitial lung disease. So I'll be showing a few projects related to those two main themes. So first, for the outline, I'm going to talk a little bit about what are interstitial lung diseases for those of you who are not familiar with that, with this disease. And then I'm going to spend maybe half of the time on this project, this systemic autoimmune rheumatic disease associated with the ILD project, which is really a really cool McGill-wide multidisciplinary project. And then I'm going to talk about some of the research I've done on gender-based disparities in access to care for ILD. So what are interstitial lung diseases? Interstitial lung diseases, sometimes we use that word ILD, interstitial lung disease, sometimes we use pulmonary fibrosis. We tend to use them interchangeably, but really interstitial lung disease are a group of lung disorders that are characterized either by inflammation and or fibrosis of the parenchyma of the lung itself. And we tend to classify them by etiology or underlying cause. So a big cause, about 30% of interstitial lung diseases are due to autoimmune diseases or rheumatic diseases. Things like scleroderma, rheumatoid arthritis, inflammatory myopathy, Sjogren's syndrome, and so on. So the immune system is dysregulated, causes inflammation, which then leads to fibrosis in the lung. Another big category are things like environmental triggers. So we think of it like occupational exposures, patients who've worked with asbestos in the past or silica or things like that can develop interstitial lung diseases, but also other environmental triggers like bird feathers, molds, those kinds of things. There's a big category that we classify as idiopathic, meaning of unknown etiology. And the most sort of prominent one is this disease called idiopathic pulmonary fibrosis, IPF, which if you look at the literature accounts for about 30% of all types of interstitial lung diseases. So it's very important, and we'll spend quite a bit of time talking about that today. So we classify by etiology, but we also classify by pattern of disease. The pattern of disease really is looking at the microscope, what does this look like, but also looking at the CT scan, what does the disease look like on CT? And all these different etiology can present with different patterns of disease. So you have this usual interstitial pneumonia pattern, which is the worst, most fibrotic, most progressive, with the poorest prognosis, which we see in some types of autoimmune diseases, but specifically in IPF, idiopathic pulmonary fibrosis. And then we have other patterns that are more or less inflammatory. What's important to remember is that overall interstitial lung disease have different trajectories. So depending on what the pattern of disease is and the underlying cause, some ILDs are at least partially reversible or can improve with treatment. Some of them remain stable over time. There's quite a high proportion of patients with ILD that do have progressive disease. And if you look at patients with ILD overall, the mortality is quite high. It's variable based on the type of ILD that the patient has. But if we look at IPF or idiopathic pulmonary fibrosis, which, as I said, is the most fibrotic, progressive, worst, the median survival of the mortality, or the median mortality, I guess, is around 4 to 5 years from the time of diagnosis. So it's very devastating diseases. So I want to start with a quote by my colleague in rheumatology, Ines Colmena, Dr. Ines Colmena. She said to me very recently, together is the way to do anything these days. And I think that's true. And I think that's what I want to highlight today. So the first project that I'm going to talk about is this project that was actually spearheaded by Dr. Ines Colmena from rheumatology. And a couple of years ago, she had this idea that she should work on grouping a bunch of investigators together to write a project, a whole research program really on better understanding autoimmune related ILD. And so this term SARS, systemic autoimmune rheumatic disease, we used to call them connective tissue diseases, related ILD. So remember that I said about 30% of all our patients with ILD have an underlying autoimmune disease like rheumatoid arthritis or scleroderma and so on. And very little is known about why some people with rheumatoid arthritis develop ILD and why some people with myositis develop ILD and why some people develop a certain pattern of ILD like UIP and some other people develop a more inflammatory, more reversible pattern of disease. And so she had this idea of getting 4 of us together to write this grant, and that we submitted to MI4, and actually we got funded. And I think what's really cool about this project is that it's really a multidisciplinary, multi-center within McGill collaboration of a bunch of people who have different but complementary expertises, but also at different stages of experience. So Ines, myself, Christian Pinault, who's a rheumatologist, and Sylvia Vidal, who's a basic scientist at McGill, we are sort of the 4 PIs on this project. And the overall goal, I'll show you a little bit of the objectives, but we put together a team of investigators at McGill, at the Jewish, and at the RI, some clinicians, some basic scientists, some people at the McGill genome, to work on this question of better understanding systemic autoimmune rheumatic disease-related ILD or SARS-ILD. So the overall objective of our SARS-ILD project is to understand the complex interplay between demographic, environmental, and genetic mechanisms that impact onset, severity, and outcome of SARS-ILD through dysregulation of the immune system and pro-fibrotic pathways in the lung. And this comes really from trying to understand, here you have all the diseases, all the different systemic autoimmune diseases, rheumatoid arthritis, scleroderma, lupus, inflammatory myopathy. And here you have the different patterns, with UIP being the most common and then sort of the most fibrotic, and some here being more inflammatory. But you can see there, you can have many different patterns with many different diseases. And so why does that happen? We don't really understand, and we don't really know. So the goal is at least to try to understand or start understanding some of this. And the key clinical questions that we will try to answer during the next 4 years as we're working on this grant and on this project is number one, prediction of SARS-ILD. Which patients who have underlying systemic autoimmune diseases are likely to develop ILD? But also pathogenesis. Why is there such heterogeneity in ILD type in terms of progression, in terms of severity of patients with ILD? We're going to also look at SARS-ILD treatment, which are the best therapies for patients. So who are the patients in whom we should start an anti-inflammatory medication, who's likely to respond better to an anti-inflammatory medication, and who's likely to respond better to an antifibrotic medications. And so those are big, broad questions. I'm not saying we're going to answer all of this in detail, but that's what we're going to try to tackle. And so through a series of projects that we propose, we're going to try to tackle those sort of three main questions. And so it's really, it's preclinical models, it's sort of translational models, but also clinical work that we're going to try to address those questions. So really in a multidisciplinary fashion. Part of this is going to be looking at novel mouse models with Dr. Vidal, for instance, and her team and other researchers. We have collaboration with Dr. Moret, who does lung on a chip model, which is this very cool technology where he can basically put like lung tissue on a chip and make it do all sorts of things. We're going to look at genetics and genomics of patients. And then sort of where I'm a little bit more involved in is going to be more of the clinical projects. So the longitudinal prospective registry of patients and a biorepository, but also a project looking at lung biopsies in SARS-ILD. So I'm going to talk a little bit more about what I've been doing in the past year with this MI4 grant with the SARS-ILD project, which is setting up a longitudinal registry of patients with SARS-ILD, as well as a biorepository of samples. So I'm speaking fast, I could slow down, I think I have time. So longitudinal registry and biorepository. So the objective of this longitudinal registry is to take well-phenotyped, well-characterized patients who have underlying SARS-ILD, and one, to better understand the disease evolution, but also to gather material samples, serum cells, genetic material, and tissue that will allow us to conduct mechanistic studies with the help of our partners. And then also to facilitate access to patient-oriented studies that are planned also to better understand patient preferences and patient goals and patients' priorities, and also to facilitate eventually clinical trials for these patients. So those are the broad objectives of why are we building this prospective longitudinal registry. Our population, so who are we including? We're basically including all cases of SARS-ILD that we can identify within the MUHC or the JGH, either outpatient or inpatient. And we want to look at adults, of course, because we're adult physicians. And we're going to look at both prevalent cases, so patients who have already had the disease of SARS-ILD for many years, or incident cases. So we're also going to enroll prospectively new patients who are recently diagnosed with the disease. And the reason why we included not just incident cases, but also prevalent cases who may have had the disease for longer, who are at different stages in their disease, and who may have been treated already, it's because incident cases of SARS-ILD that are untreated are really not that common. We see them maybe, you'll know if you do some clinical medicine, we see them on the ward sometimes, we see them in our clinic, but it's not that often that patients with a new diagnosis of autoimmune rheumatic disease ILD present. We will eventually try to expand to patients who have SARS only with no ILD, but those registries already exist even within the RI-MUHC. Dr. Pino is leading several of them already. So there's, and Dr. Bernatsky as well, there's the RA cohort, there's the lupus cohort. So we really wanted to focus our efforts on recruiting patients with SARS-ILD. The patients, of course, have to give consent and sign the consent form and agree to participate. They also agree to have samples sent, so blood work, but also any samples that are obtained for clinical reasons, they allow us access to using these samples if they sign the consent. It's clearly written. And the way we set up this registry is that we'll have initial visit with different measurements that I'm going to get into, and then annual visit. And then at these visits, they're seen by a respirologist and a rheumatologist together in this special clinic. So what do we capture at each visit? So we capture, it's a long questionnaires for the patients and for us, but we try to be as comprehensive as possible in terms of gather information. So we're going to capture things like demographic, but also detailed medical history, medication history, etc. We do a rheumatology evaluation that will include a rheumatology physical examination, the type of diagnosis, serologies, joints affected, and so on. We capture quite a bit on their ILD itself. So what does the lung function look like if we have pulmonary function tests, but also if we have 6-minute walking distance exercise tests, and then chest imaging. So what does their CT scan look like? What's the predominant pattern of disease? That's going to be really important down the line to be able to look at different phenotypes of patients, if I may. We're capturing things like blood work, autoimmune serologies, muscle enzymes, liver enzymes, those kinds of things. And then the patients fill out a number of quality of life, health-related quality of life questionnaire, dyspnea questionnaires, some questionnaires that are ILD specific, and some questionnaires that are SARS specific. So, and then all of this data gets, that's generated and then gets entered by the research coordinator into REDCap. In parallel to this, we're doing a biorepository. So we have this prospective longitudinal registry of patients, and then in parallel, we have a biorepository that actually is co-directed with Gregory Fonseca from the Meekins lab, also at the RI-MUHC. And Greg is participating in this study and has agreed to help, but to process the samples as they come. And what we're capturing at every visit is going to be serum, DNA, RNA, and PBMCs. These are at every visit, blood draw, 5 tubes, and then they get sent to the Meekins lab. If they're untreated patients, we do have a study currently where we're looking at the single-cell RNA sequencing and immunophenotyping for these untreated patients. So we do send them to Dr. David Langlet's lab at McGill Genome, and we're going to repeat those analyses after we start treatment to compare to see what happens. So that's just one experiment that's en cours, but all the other samples are being kept in our biobank. We are hoping to also keep tissue samples that we acquired in a clinical setting. So we're not asking patients to undergo bronchoalveolar lavage bronchoscopy or lung biopsy, skin biopsy, or muscle biopsy in any way for the purpose of this study, but we are asking that if they undergo these procedures for clinical reasons, that we can take a small piece that's not being used for the clinical setting, if we can keep a small piece of that in our biobank. And so far, what's our progress been? So we've been working on this for just over a year, and we've written all the protocols and the consent forms. We've submitted all of that to RAB approval, which finally we got RAB approval, took a while. We developed the biobank framework with the help of Inga as well, who's been really instrumental in helping us with this. She's been really wonderful at the Meekins. We built the REDCap database, and then we actually started enrollment about six to 8 weeks ago. And we already, I want to say five patients enrolled, or 6 patients enrolled so far. It's a little bit slow going at the beginning. We have a little bit of growing pains, but overall, like we've done quite a bit of work. And as I mentioned also, we already have some experiments en cours with Dr. Langlet at Genome McGill to look at pre and post treatment, what does immune cells look like in these patients. So it's very exciting. It's a very big team, and we have frequent meetings and where we discuss different things at each meeting. But overall, hopefully this will pay off in the next 4 or 5 years. One other thing that came out of this SARS ILD project is actually using the collaboration that I'm building with the SARS ILD to help sort of enrich projects that I had already started before this program. So that's what I want to talk about next. So I want to talk a little bit about treatment and response. I'm going to preface this by talking just 1 minute on antifibrotic medications in ILD and IPF. So antifibrotic medications, there are 2. One of them is nintedanib, and the other one is pirfenidone. Those are the 2 approved antifibrotic medications in Canada. And antifibrotic medications are medications that have been used to slow down disease progression in IPF, and they've been shown over a 1-year period to slow disease progression for patients who have IPF, which is not the same as autoimmune or SARS ILD. But still, they have been tried also, these antifibrotic medications, in progressive fibrotic ILD. And also, these 2 medications also show benefit in slowing down disease progression for other types of progressive fibrotic ILD, including some groups of SARS ILD or autoimmune ILD. The problem is that in these trials of progressive fibrotic ILD, all the patients who are on heavy-duty immunosuppression are excluded from the trial, except if they're on mycophenolate. And so a few years ago, I started this project where I wanted to take patients who almost always are on immunosuppressive medications for their autoimmune disease. So I wanted to look at patients with autoimmune inflammatory myopathy. There are patients who have an autoimmune disease that affects the muscles, causes inflammation in the muscles, in the joints, in the skin, but also in the lung. And these patients were largely excluded from the trials of antifibrotic, of progressive fibrotic ILD, because they're often on rituximab, on azathioprine, on mycophenolate, tacrolimus, or a combination of those. And so then I wanted to see if we could use antifibrotic in these patients on top of their immunosuppression, which they need for muscle and joint and skin disease. And I wanted to assess whether it's safe and tolerable. I'm looking specifically at nintedanib, which is the antifibrotic that I mentioned, one of them. And I designed this trial where it's basically an open label, single arm study of everybody goes on nintedanib. I'm hoping to recruit 25 patients, basically to assess safety and tolerability, in addition to their existing medication. Secondary endpoints are going to be to look at 6-minute walk test, the lung function after the treatment with nintedanib. But then we started this MI4 project with SARS ILD, and then we thought it would be great to incorporate to use this trial to better understand the effect of antifibrotic medication in patients with SARS ILD, specifically on immune cells of circulating cells in patients who are enrolled in this study. So that sort of got added on. So the study we're going to look at, we're looking at, not we're going to, it's launched and we're recruiting patients. The study is looking at patients with progressive ILD in patients with a diagnosis of autoimmune inflammatory myopathy, 9 visits over 24 weeks. I wrote 26 weeks in the previous slides, but it's actually 24 weeks. And what we're going to do is capture all the adverse events and adverse effects, blood tests, specifically liver enzymes and CBC that can both be affected by immunosuppressants and by nintedanib. And we're also adding on immunophenotyping pre and post nintedanib to try to understand response to treatment on sort of immune physiologic way. We've already enrolled 4 patients. We're about to recruit our 5th patient, to enroll our 5th patient out of expected or hopeful 25 patients over 2 years. So that's also, if you have patients who fit this criteria, send them my way. I'm looking to recruit more patients, but that's ongoing, and that's also seems to be very well tolerated so far. And I'm going to switch gear a little bit. And for the rest of the talk, I want to talk about the second theme of my research, which is more to look at discrepancies in care of ILD and IPF. And I mostly started looking at gender-based imbalances and disparities. And the way I split this is to talk about projects that look at gender-based imbalances in diagnosis, in treatment, and in clinical research of IPF. And then I'll have a couple of slides on the next steps that I'm planning. So some of you may have heard about this already. A couple of years ago, I looked at the effect of gender, patient gender, on the diagnosis of idiopathic pulmonary fibrosis. So I wanted to know how much gender impacts the likelihood of receiving a diagnosis of IPF. We think of idiopathic pulmonary fibrosis as predominantly male disease, which is sort of what the prevalence and epidemiological studies show us, maybe a 30% women with IPF and 70% men with IPF, something like that. But I felt like often when I was at conferences, the first thing that we saw on all of the slides was like the picture of the poster child for IPF, which is always an older man with a bottle of oxygen. And I'm like, well, where are the women with IPF? So I wanted to see how gender influences the diagnosis. And so I reached out to Simon Walsh, who's a radiologist in the UK. And Simon, a couple of years prior, had done this really cool study where he put together 60 consecutive cases from his center in the UK. And he wrote up, you know, the clinical vignettes. He put a CT scan, the actual patient CT scan, the bronchoalveolar lavage data, and he sent these 60 cases, and he sent them to over 400 pulmonary physicians to read and score on this sort of survey platform. And the physicians who read the 60 cases had to go over the case and put their top diagnoses and their confidence, how confident they were in making their diagnosis. And so I thought this would be a great way to assess how patient gender influences the likelihood of a diagnosis of IPF. And what I did is then I used this data and I used logistic regression basically to assess the odds of a patient receiving a diagnosis of IPF based on their gender. And I adjusted for confounders that I felt would influence the relationship between gender and diagnosis of IPF. So what I found was that overall men had 3 times the odds of receiving a diagnosis of IPF compared to women overall. And this was after adjusting for older age, for the presence or absence of autoantibodies, presence or absence of smoking, occupational exposure, which tend to occur more frequently in men, and the serum precipitants, which we sometimes see in diseases other than IPF. But then I thought, you know, let's push this a little bit farther and look actually at disease pattern on CT scan. So you'll recall earlier I talked about the usual interstitial pneumonia pattern, or UIP pattern. And UIP is sort of like, this is the definition of IPF. If you have no underlying etiology and you have a UIP pattern on CT, the guidelines say that this makes a diagnosis of IPF, or idiopathic pulmonary fibrosis, so you can stop there. So then I wanted to stratify by CT scan pattern, by UIP pattern, to better understand, you know, to better, I guess, adjust for CT scan pattern. And what I found was actually in patients who have the definite usual interstitial pneumonia pattern, whether they're men or women, it doesn't make a difference. If you have the usual interstitial pneumonia pattern, you're going to get a diagnosis of IPF. Your gender doesn't matter. Where your gender matters as a patient is if your scan is not typical for UIP. If your scan is probable for UIP, indeterminate, or suggestive of another diagnosis of ILD, then male gender becomes very important and really pushes the clinician from making a diagnosis towards IPF. And then I looked at diagnostic confidence, and male patients across the board received a stronger, more confident diagnosis of IPF. Like the diagnostic confidence for male patients for IPF was systematically higher than for women. So to me, this study really reinforced the fact that when clinicians look at a case, a patient, they really use gender a lot in their diagnostic algorithm, and gender has quite a bit of weight in making the diagnosis. Then I wanted to look at this should say gender-based differences in the treatment of ILD, specifically in Canada. So I participate in this cohort study, which is the Canadian Registry for Pulmonary Fibrosis. So this is a prospective longitudinal cohort study of patients with ILD across Canada. This was spearheaded by Chris Ryerson out of UBC. And currently we are 8 participating centers across Canada, including our center and the CHUM as well. We have 2 centers in Montreal. And basically the objective of the Canadian Registry is just to capture all patients with ILD and capture their data, their clinical data, their diagnostic data, but also prognosis, exacerbations, and so on. The only inclusion criteria is that the patient has to be an adult and have ILD and present at one of our centers to get enrolled. So I thought it would be a really good platform, a really good data set to look at whether gender impacts treatment initiation in IPF and in other ILDs. I do want to say I'm looking at gender in this cohort because we do capture gender in the CURE-PF. We have a handful of transgender patients, so we can actually look at sex and gender, but for this I looked at gender. And what I wanted to look at was time to treatment initiation of a first instance of an ILD-related medication. And I defined time to treatment initiation as the time between the date of diagnosis of the ILD, which is defined as the date that ILD is first identified on a CT scan or on a lung biopsy, and the date of the first instance of an ILD-related medication. And the medications that I looked at were the antifibrotics and a number of immunosuppressive medications like azathioprine, mycophenolate, rituximab, cyclophosphamide, and a few others. I used Cox proportional hazard modeling to determine how patient gender influences time to treatment initiation. I adjusted for several variables that I felt were confounders in this relationship. And I also looked at survival between those that receive treatment and those that do not, which I stratified by gender. And the advantage of using the Canadian Registry for Pulmonary Fibrosis is that it's actually really well balanced between men and women patient. About half of the patient are women, half of the patient are men. At the time that I pulled this data, there were just over 2,000 patients in the registry. At this time, we have almost 4,000. So I will be repeating before publishing this. I will be repeating these analysis, but this was what I presented at the abstract conference. The other advantages of the Canadian Registry data is that it's first of all, it has a lot of connective tissue or SARS ILD, but also it's quite well balanced in terms of the diagnoses. So the results. So I found no difference in proportions of patients that were treated over time. So men and women were treated in the same proportion over the duration of their follow-up. However, time to treatment initiation was significantly lower in men compared to women. And that was true across all diagnoses, but specifically this was stronger for patients with IPF, meaning that men get treated earlier than women, especially if they have IPF. This was true after adjusting for age, for severity of lung function, namely with forced vital capacity and diffusion capacity. That was true. This is the adjusted analysis. So men, the hazard of treatment was 1.61 compared to women, and that was still statistically significant. And the IPF patients really sort of influenced the total, all of the population. Because if once I stratify by diagnosis, you see that the other diagnoses are no longer statistically significant after adjustment for confounder. And then here, so this is the time to treatment initiation. So men just are treated just earlier. And what I didn't show, I showed in the other, I thought I had a slide, but I don't have it. I'm sorry about that. But when I looked at survival, actually, of course, survival in a cohort study is very heavily biased. But when I looked at survival, there was really no differences in survival between the men who were treated and the men who were untreated. But in the women who were treated and untreated, there was a significant difference. And so it seemed to be even more important for women to be treated, although that caveat is that there are confounders with this. So then I reached out to some friends at the University of Chicago and some friends in Australia. And they have cohorts that were similar to our Canadian Registry cohort. And so I wanted to see if these findings could be replicated in other cohorts. So I'm still waiting for the Australian Registry data, so I can't show you this, but do have the data from the Chicago cohort. And what they found really was like, they found the opposite of what we found. They found that actually women were treated earlier than men. And actually in their cohort, women were treated in slightly higher proportion than men during the follow-up. And if you look at the survival, remember I said I didn't show you the graphs, I'm sorry, but I said that in men, there was no differences in survival between those that are treated and untreated, but we did find one in female, but they actually found the opposite. So I don't know what to make of it. I really am looking forward to receiving the data from Australia to see what they have in their cohort. There are obviously differences in our cohorts. University of Chicago has a much more racially diverse cohort, which is a definite strength of their cohort. We have a little bit more patients with connective tissue disease that would have been treated earlier, maybe because of their extrapulmonary manifestations and not just for their ILD. They don't have that much in Chicago. So there are a few differences that we have to explore, but I thought it was really interesting. I don't really know yet what to make of it. I'm waiting for our third cohort to see. And then finally, in the last, I guess, 6-7 minutes that I have, I want to talk about a systematic review and a meta-analysis that we actually just recently resubmitted to ERJ, looking at patient gender and enrollment into clinical research. So I wanted to look at basically the representation of women in clinical trials of IPF compared to the population proportion of women who have IPF in prevalent studies. And we searched the literature for randomized control trials of IPF treatment, but also for observational studies where we felt we could assess what proportion of women exist or live with IPF. And to get at that, we looked at prospective longitudinal registries like the CARE-PF registry that I just talked about. But we also looked at population-based administrative data to try to get at like the sort of the true prevalence of women with IPF. Our inclusion criteria were that the studies had to have at least 50 participants, either in French or in English, and that the participant, they had to show data stratified by patient gender. So it's a bit busy, but summarize our findings. When I looked here at randomized control trial here, women made up 22% of participants in clinical trials of treatment for IPF. When I looked at prospective longitudinal registries, women made up 27% of all participants, all IPF participants in registry. When I looked at database study, population-based database study, looking at diagnostic codes, women made up 42% of IPF diagnoses. So there's definitely differences in, there's likely, I should say, there is likely underrepresentation of women in clinical trials of IPF. Now, the question that came up when we had the first initial peer review of this, when I submitted this article is, well, what's the true prevalence? What's the true proportion of women who live with IPF? And the answer is actually, we don't really know. It's very difficult to assess prevalence of IPF using, administrative data study because they're at risk of misdiagnosis. Probably the true answer lies somewhere between what we find in registries and what we find in administrative data studies. I do think that women are underrepresented in clinical trials, but probably not by 20% difference. Probably the true sort of difference is somewhere in between. Next steps, I want to talk about some next steps. So I'll show you this slide and then I'll go back to that. So the next steps, I want to assess gender-based disparities in other cohorts, not just the Canadian cohort. I want to look at gender-based disparities in other types of interstitial lung diseases and at different time points in their trajectory of the patient care. So this is from the CIHR grant that I recently submitted a couple months ago, where I'm proposing to look at Canadian Registry for Pulmonary Fibrosis, but also the British Thoracic Society IPF registry. And they've really kindly agreed to share their data and they're with me for this project. We're at the contract negotiation stage of getting a data transfer agreement, but colleagues in the UK have agreed to share this data with me, and so that's very exciting. They have also a prospective registry of patients with sarcoidosis and IPF. I'm going to be focusing on the IPF patients. They have almost 3,000 patients. They're a bit older because they all have IPF. In the Canadian registry. We have younger patients because we have autoimmune patients and occupational disease and so on. That's why also the female proportion are different. Their registry is quite low on women, but so I'm hoping to use these two cohorts to basically look systematically at all points of care, or all points in the trajectory of care of patients with ILD, in terms of like, are there disparities, racial disparities and gender-based disparities in medication initiation or discontinuation, in access to pulmonary rehabilitation, in initiation of oxygen, and in referral to lung transplant. So that's what I'm hoping to look at sort of in a systematic fashion in the next couple of years using these databases, these registries. And then the other thing that I'm interested in looking at are going to be sort of more qualitative type research to better understand the clinician's perspective on gender and care, and also the patient's perspective on race, gender, and care. So that's kind of what I'm working on. And with that, I think I'm done with quite a lot of time for questions. So I would welcome any question that you have. I'll stop sharing, I think.
Thanks, Deborah.
Any questions?
That was a really awesome talk. It sounds like your program has a lot of avenues, which is strategic usually. I have some questions, but maybe I'll start. There's a question in the chat that came midway from Anna Moga, who's wondering if you could comment on the approaches used to obtain patient preferences.
Yeah.
And also, sorry, she also wondered what quality of life measures you were going to use.
So the patient preferences study, we haven't started yet, but we're looking at putting together small groups of patients and really doing more qualitative type research where we're going to do focused interviews and small groups. All of this got delayed due to COVID and the inability to meet with small groups of people, or even, larger groups of people. But that's the idea, to actually, more and more clinical research is looking at patient involvement, and I really strongly believe that patients need to be involved in what they feel their priorities are, and having patient representative on research teams, I think, will be so important. One of the weakness of, I'm going off on a tangent, but one of the weakness I think of our MI4 project so far is that we don't have patient representative on our team. I think it would be it would really add to our work. So we're going to be looking at patient interviews and questionnaires and surveys, and we're going to send through different, foundations and associations to try to get at what their priorities and preferences are. And the quality of life. So I'd have to go back to see if, certainly for the respiratory, I have to go back to see what rheumatologic questionnaires we're looking at. But for the respiratory, we're looking at St. George's Respiratory Questionnaire, which has been validated in ILD. And we're going to look at a K-BUILD questionnaire, which is also in the process of being validated, especially in IPF. So those are some of the quality of life measures that we're going to be using.
So I guess I'll ask my question. So I like how your program is really kind of developing something locally, but also you're involved nationally and even interfacing with other cohorts. That probably will serve you well. So one question just relates to sort of operation, like it's an operational question, is this local project that you're starting, I don't know if registry is the right word, but with the biobank and all this multidisciplinary expertise, that sounds like it'll be really rich and valuable. How do you, because that's sort of like a long game, and how do you fund something like that long term, like the biobank and so on and so forth.
Yeah.
The data extraction and like all that stuff. I guess a lot of it is actually clinically indicated, but never, I always underestimate all the effort of actually taking all those variables and incorporating them into like a research database.
Well, yeah, I mean, that's the question. Like, how do you sustain this? So right now we have funding for 4 years. So we built it in our research proposal. We built, we budgeted money for a biorepository. That was a really key part of our project. The goal is to use those 4 years to generate important data and important experiments that are going to be used to then apply for more grants. Basically, isn't that the name of the game? Get money to get more money. So that's kind of like the idea, that then we're going to apply for more CIHR money and more funds, and then using this growing, I guess, database and biobank, then that becomes leverage also to get more money, right? Like, so if we already have an established biobank with samples that are and expertise, then you're going to be more likely to get funding, from what I understand. So that's kind of the idea, but yeah, it's tricky. It costs a lot of money.
Mm-hmm.
And I guess the advantage also of having multiple investigators involved in this project is that we share the cost burden as well of that.
Mm-hmm.
So
yeah, it's not, I mean, I don't have an answer. It's not easy, but I think that what you're describing makes a lot of sense. I think that's how a lot of these things work. It's kind of sad that it's so hard to find that funding, because there often end up being extremely rich sources of data. I suppose another source, if you had this huge registry of patients with ILD of whatever etiology, you could presumably kind of quickly recruit for clinical trials, which might be a source of revenue. I don't have experience in that space, but that would be another stream of revenue to maintain this thing.
Yeah, so that's one thing. The other thing is the Canadian registry. I mean, we get a small amount per patient that we enroll. And the idea was that, yes, we're setting up this biobank for the SARS ILD project, but, Greg Fonseca and I are already talking about the patients. If we can get the patients who are already enrolled in the Canadian registry to draw their blood at their initial visit and then biobank for our own use, obviously the patient would sign a consent form specifically for this,
Mm-hmm.
but then, we build the infrastructure. That's the hardest part, I would say. And then once you build the infrastructure, then you have the software, the management, all of that, then you can add to it. And then you can use money from you can use revenue from different sources.
Mm-hmm.
Clinical, in my very small experience of clinical trial, I have not found that there was a lot of money left over from the clinical trial. I was hoping there would be more that I could then channel into my own research. I haven't found so far that it's all that useful. I continue to do clinical trials because I think it's important for our patients who really don't have a lot of therapeutic options. But it's a lot of work, with not a lot of benefits as a researcher.
Mm-hmm. I wonder if someone like Jean Bourbeau or others might have advice about how to, I mean, whether it's an avenue that's worth maintaining. I mean, I agree with you completely that engaging in that so that patients have that option to, I mean, that's sort of really key. We see it much more in the oncologic space, I think, where, that's a big component of being an academic center, I suppose, is having these cutting edge, quote unquote, cutting edge trials especially for people with limited treatment options. Anyways, I guess I have another question related to more pivoting to the science itself. So the different results you're seeing locally versus, I guess that was Canada-wide versus, you said, it wasn't unclear to me, the University of Chicago, but then I think you mentioned Australia at some point. So maybe I misunderstood. The data where there was a different result was coming from the US or from Australia?
From Chicago.
Okay, so I must have misheard. Yeah, so one wonders about, obviously a big difference there might be access to healthcare. And so you mentioned the race ethnic diversity as well, but so you might want to try to collect that, or, I would also look there in terms of, over 65, the access to healthcare may be more standardized. And so to stratify by that or look into those sorts of healthcare access socioeconomic indices that might help untangle some of that. The question that you had, so in your meta-analysis that you're doing that you said you submitted to ERJ, that's also interesting, very interesting, I think, related to the proportion of men versus women being enrolled in trials versus what's seen in other sources of data, and what is the quote unquote true, like what's the ground truth, if you will. So I guess in your large registry data from Canada, that's at the very least, that's like clinically relevant ILD of any kind. And whether people are being women or men are being misclassified as IPF versus other ILDs, the proportion, it must be somewhere between those two. Kind of, like, what was the proportion of women in the IPF in your data set and other ILDs in your data set?
So yeah, so
the true proportion is probably somewhere in between.
So
it can't be outside of those bounds, I don't think.
I think, oh, you asked me a lot of questions in like a few sentences. So I think the true proportion of women with IPF is unknown. I think the true prevalence of patients in the world with IPF is unknown. The estimates vary widely. I think that in the Canadian cohort, it's around 27% or something like that in our Canadian cohort. But I think that getting in a registry is not the same as the people who don't get in a registry. So getting in a registry is a layer of access to research that is not the same as the general population with IPF. In order to get into a registry, and that's true worldwide, you have to be seen in an ILD center. To be seen in an ILD center, you have to be referred to an ILD center. And so I think there's likely referral bias, and there's even like somebody needs to make the decision, I'm going to approach this patient for enrollment into a clinical trial. So are these registries enrolling all patients with ILD? Are they offering it? Like, are they systematically enrolling everybody? Or obviously, like, so even if you offer to everybody, so first you already had to have a referral bias to be referred. Even if you offer it to all your ILD patients systematically, then who are going to be the women equally likely to say yes as men? I would argue not necessarily. Or are, I even looked at racial disparities, racial differences. Are people who are non-whites as likely to get enrolled into a registry as a white patient? And I would argue that the answer is no. Women may be less likely. Maybe they're caregivers. Maybe they don't have time to fill out the questionnaires because they have to go home to their, elderly husband that they have to take care of. Like, I would argue it's not the same thing. So I think that the true proportion of women with IPF is somewhere between what diagnostic code administrative data study tell us, which is misclassifying bias, and what the registry tell us. But I got a ton of pushback when I submitted it to ERJ the first time. I got a ton of pushback from reviewers saying administrative studies using diagnostic codes are garbage and you have to remove them because there's too much misclassification. And it's true, there's probably is misclassification, but I don't think that registries, longitudinal prospective registry reflect the true prevalence of the true proportion of women with IPF or the true proportion of racialized patients with IPF or the true proportion of people with a lower socioeconomic status with IPF. So I think all of those things add to the disparity in clinical research. And what was the other question that you asked me? I spent so long answering those
that I think that was it. The initial was just a comment about what to look for between Chicago and Canada when you get those data. But I mean, I guess I hear what the reviewers are saying about the registries and what you're also, I mean, I agree with your interpretation. I think the bet, like what is in the ideal world, if you could systematically in a population-based fashion, scan a bunch of people and ascertain, because there's the people who are getting these clinical diagnoses and showing up in health registers, like health databases. There's the people in your registries. There's the people who have real ILD that are just being misdiagnosed entirely and are just out there suffering. And then there's probably a bunch of people with very mild disease who are probably not, like, I don't think are as, maybe you're not that interested in. So I guess, I know we've talked about this before, but I don't know if there's population-based cohorts that have done CT scanning, where I know that there's more to diagnosing ILD than just looking at the scan, but at least at some base level of like, okay, this many people had legitimate honeycombing or whatever, just to get some rough estimate, because it is important, I guess, towards your program about this gender disparity or difference, like knowing what is the ground truth, I think will keep coming up.
What's the absolute truth in the universe? We don't know.
Yeah. Anyways, okay. So yeah, but you're right. And that cascade of like all the different levels where where disparities or differences can get introduced. It's like at every single step. That I definitely agree with you.
So
Okay.
there's one question that just came up. So what's the distinction that we're making between sex and gender in our study? Okay, so such a great question. It sounds simple. Sex is the biological attributes and gender is a set of social cultural, social cultural, what do I want to say? Attributes that make up gender. And sometimes we can't tell because the studies are not making a difference between sex and gender. I would argue that the majority of clinical trials that I looked at report actual sex and not gender. In our registry, as I mentioned, we do have patients self-identify their gender. So I feel like that is a good representation of what their gender is. Sex is also a little bit more complicated, like to get at, because we don't have just XX, XY. There's like a wide variety of different biological, sexual, chromosomal things. So it's difficult. It's a loaded question, but an excellent question.
Yes, and that's why I asked it, because it seemed to be that you were using male and female in the different tables and graphs, and then male gender to cover both aspects of the issue. And I think that there is a tremendous amount of distinction to be made between sex and gender. And I think that gender includes a lot more variables than just sex, right? And I think if you're not questioning or having access to those supplementary information about gender, then you're really talking about sex, right? And I think that that's what most people have in their databases and in their data sets. And that's why I would caution you about using the word gender, unless it really is a gender study. Because I think it does influence the questions that you're asking, because it seems to me that you are questioning whether there is a difference in treatment or other modalities that are more liable to be sort of in the male trajectory of the disease as opposed to the female trajectory of the disease. I'm not sure. And I'm also wondering why you think that might be so.
Yeah, so first of all, thanks for your point. You're right that I'm not necessarily very rigorous in the way, and I have to be more careful in the words that I use. So thank you for that point. That's very well taken. I think that there are probably biological differences in the disease. I do think that that's true. That's largely unexplored. And I think that there's not a lot of sex and gender researchers in the world of ILD. And it's not something that is thought of very much in this sort of in the world where I work, and that shows up also a lot in it's obvious in the research that it's not well characterized, and
that's a very important point. And so when you are applying to CIHR, because I'm just reviewing in a CIHR competition, and of course gender is one of those big items that CIHR has decided that they really want investigators to think about when they're putting in their grant applications. And that paragraph that you will write on gender and sex is really important for reviewers, and we really take a really good look at that. And I think that if you explain that clearly, how sex differs from gender and how you are looking and incorporating that in your research projects, I think that that would be a really good thing to do there, because it really does establish then you and it really highlights the gaps in the research that you would then be proposing. And I think that would be very powerful if you could explain that very clearly in that section of the grant application.
Thank you for your comment. Thank you.
Thanks, Teresa. There's one last question. Anna is asking to elaborate a bit more on the importance, or why you feel the need that patient preferences, or why they need to be assessed. Is it to inform treatment?
I think it's to inform what the patient priorities are for research. What are the things that are important to patients? Like we always talk about survival and treatment and slowing down the disease, but maybe for patients, it's quality of life. Maybe it's how to be less short of breath, how to cough less in public, how, so I think that informs a lot on where our research should go and what are going to be the things that are important for patients. I think that's why, patient preferences and input might be important. Sometimes what I think the priorities are not the same what my patients think their priorities are. And I think if we can align our priorities, I think that makes for much stronger research overall and more impactful for our patients.
Okay, thanks a lot, Deborah. Thanks to everyone for attending. We'll see you around.
Thank you.